today's session we will be discussing about cholinergic system. At the end of the session, you should be able to understand what is parasympathetic nervous system, what are the effects produced by parasympathetic nervous system, the receptors of acetylcholine by which it produces its action, the directly acting cholinergic agents, the indirectly acting cholinergic agents, and a disease called as Myasthenia Gravis, and also about organophosphate poisoning. So these two questions, Myasthenia Gravis and organophosphate, they are very important in a theory point of view. So in our body, there are some functions which you do not have any control of, like heart rate, peristalsis, gastric acid secretion, so we do not have any direct control over these functions. So these functions, they are controlled by the autonomic nervous system. So the term autonomy means self-rule. So they regulate these functions on their own without involving the higher areas of central nervous system. So this autonomic nervous system, they are classified as sympathetic nervous system and parasympathetic nervous system. On either side of the spinal cord, we have ganglia known as autonomic ganglia. And these ganglia, they are classified as sympathetic and parasympathetic depending upon their location and also the neurotransmitter released. So the autonomic nervous system is classified as sympathetic nervous system and parasympathetic nervous system. Sympathetic nervous system, the neurotransmitter released is adrenaline or noradrenaline, whereas in parasympathetic nervous system, the neurotransmitter released is acetylcholine. So the cholinergic nervous system is called as rest and digest system. So this is the system that activates when you are resting, and this is a system that produces all the digestive processes in our body. So the major neurotransmitter of this cholinergic nervous system is acetylcholine. And this acetylcholine is synthesized by parasympathetic neurons. I have told you earlier, there are ganglia on either side of the spinal cord, and spinal cord gives away neurons to these ganglia, and these ganglia will send neurons to different organs. The neuron that comes from the spinal cord into the ganglia is called as a preganglionic neuron, and the neuron that goes out of the ganglia to the organ is called as a postganglionic neuron. All the preganglionic neurons release acetylcholine as a neurotransmitter, and the postganglionic neurons will release norepinephrine if it is a sympathetic neuron, or it will release acetylcholine if it is a parasympathetic neuron. Some cranial nerves also use acetylcholine as a neurotransmitter. These include oculomotor nerve, facial nerve, glossopharyngeal nerve, and vagus nerve. These four cranial nerves use acetylcholine as a neurotransmitter. Acetylcholine produces its action in our body by binding to two types of receptors. One receptor is called as a muscarinic receptor, and the other receptor is called as a nicotinic receptors. So the muscarinic receptors are called muscarinic receptors because they are stimulated by a compound called as muscarin. And the nicotinic receptors are called so because they are stimulated by nicotine. So all the effects of acetylcholine are produced by binding to these receptors. The muscarinic receptors, they are classified basically into three types: M1, M2 and M3 receptors. And the nicotinic receptors, they are classified into two types: NM receptors and NN receptors. The muscarinic receptors, they are G protein coupled receptors. and they have a G protein coupled to the receptor. And stimulation of these receptors will result in dissociation of this G protein, and this G protein will activate enzymes which will produce the actions. Among the muscarinic receptors, M1 and M3 receptors are GQ coupled receptors, whereas M2 receptor is GI coupled receptor. So we will see what are the effects produced by acetylcholine, and we will see what are the effects produced by stimulation of muscarinic receptors. So this can be easily memorized by understanding what all changes happens in our body during rest. So the effects produced on muscarinic receptors are the effects in cardiovascular system, respiratory system, urinary system, gastrointestinal tract, in the glands, eye, and also in the central nervous system. In the cardiovascular system, this acetylcholine produces vasodilation. And this vasodilation is by stimulation of M3 receptors which are present in the vascular endothelium. So the vasculature do not have cholinergic innervation. But this vasodilation is produced by circulating acetylcholine by its action on M3 receptors. Also, acetylcholine will produce reduction in heart rate, reduction in AV conduction, and reduction in force of contraction. So the effects in heart is produced by action of acetylcholine on M2 receptors. In the respiratory tract, acetylcholine produces bronchoconstriction, and also it produces increase in bronchial secretions. This is by the action of acetylcholine on M3 receptors. In the urinary tract, it produces urination. So the urination is produced by constriction of detrusor muscle and relaxation of sphincter. So this constriction of detrusor muscle is produced by the action on M3 receptors, and the relaxation is produced by action on M2 receptors. In the gastrointestinal tract, acetylcholine will stimulate peristalsis. And it also increases the secretions in the gastrointestinal tract. So these effects, they are produced by the action on M2 receptors and also on M3 receptors. Acetylcholine increases secretion by almost all the glands. It increases salivary secretion, increases the secretion of tear and sweat. The increase in secretion of glands is produced by the action of acetylcholine on M3 receptors. In the eye, acetylcholine produces constriction of pupils. So this effect is known as miosis. In the eye, acetylcholine will act on M3 receptors which are present in the ciliary muscle, and this will result in contraction of the ciliary muscle. This will result in reduction in pupil size. All the muscarinic receptors, they are present in central nervous system. And in the central nervous system, acetylcholine helps in cognition, It helps in motor function. It regulates appetite. So these effects are produced by the action of acetylcholine on all the muscarinic receptors which are present in the central nervous system. So that's all about muscarinic receptors. So the effects produced by muscarinic receptors are the effects which are seen during rest. So these include effects on the cardiovascular system like vasodilation, reduction in heart rate, reduction in AV conduction. In the eye it produces miosis. In the gastrointestinal tract it increases peristalsis and increases gastrointestinal secretion. In the urinary tract it produces voiding or urination, and it increases the secretion by almost all the glands, and also it produces bronchoconstriction. So now we will see the nicotinic receptors. Nicotinic receptors are two types, NM receptors and NN receptors. So these nicotinic receptors, they are ligand gated ion channels. So these nicotinic acetylcholine receptors, they have got many subunits, and binding of acetylcholine to 2 alpha subunits will result in opening of the central pore. There is a central pore inside this nicotinic receptor. So that will result in inward movement of positively charged ions, and this movement will produce the effect. The NM nicotinic receptor, they are present in the neuromuscular junction. And stimulation of these receptors will result in movement of positively charged ions, which will result in muscle contraction. The NN receptors, they are present in the autonomic ganglia. So stimulation of these receptors will result in release of neurotransmitter from the postganglionic neuron. These NN receptors, they are also present in the adrenal medulla. Stimulation of NN receptors in the postganglionic neuron will release in neurotransmitter release. And in the adrenal medulla, it will result in the release of catecholamines. So basically, two types of receptors are there for acetylcholine: muscarinic receptors and nicotinic receptors. Muscarinic receptors, they are classified as M1, M2 and M3, and nicotinic receptors are NM and NN receptors. So now we will see how acetylcholine is metabolized. Acetylcholine is metabolized by an enzyme called as acetylcholine esterase, and this metabolizes acetylcholine. So there are two types of cholinesterase enzyme. One is acetylcholinesterase, which is called as a true cholinesterase, and the second type is called as a butyl cholinesterase or pseudocholinesterase. So acetylcholinesterase, they are present in the neuromuscular junction. They are present in areas where acetylcholine is released. And the function of this enzyme is breaking down acetylcholine. Once this acetylcholine is broken down, there will be formation of acetate and choline. And this choline will be reuptaken by the presynaptic neuron. And this choline will be used for synthesis of acetylcholine. The second type of cholinesterase enzyme is butyl cholinesterase or pseudocholinesterase. So these enzymes, they are present in the plasma and also in the liver. So the function of butyl cholinesterase is to metabolize the injected or ingested cholinergic agents. The cholinergic drugs, they are classified as directly acting agents and indirectly acting agents. One directly acting cholinergic agent is used in clinical practice. This is pilocarpine. So pilocarpine, it acts on cholinergic receptors similar to that of acetylcholine. Pilocarpine is used for the treatment of glaucoma, and in glaucoma it is a third choice agent. Indirectly acting agents, they will inhibit the enzyme acetylcholinesterase. So this will result in reduced metabolism of acetylcholine. So this will result in increased levels of acetylcholine. So these indirectly acting agents, they are called as anticholinesterase, because these agents will inhibit the cholinesterase enzyme. So these agents, they are classified as reversible agents and irreversible agents. Reversible agents reversibly inhibit the cholinesterase enzyme, and irreversible agents will irreversibly inhibit the cholinesterase enzyme. First we will see the reversible agents. The reversible agents are physostigmine, neostigmine, pyridostigmine, donepezil and galantamine. So these are the reversible agents which are used clinically. And the irreversible agents, they are commonly used as insecticides. So the effects produced by anticholinesterases, they are similar to that of the effects produced by acetylcholine. So the effects are in the eye, gastrointestinal tract, in the neuromuscular junction, cardiovascular system, in the glands, and also in the genitourinary system. So these effects, they are produced by increased levels of acetylcholine. So you need to remember only the effects of acetylcholine, and these anticholinesterase will produce the same effects. So in the eye, it produces miosis or pupillary constriction. In the gastrointestinal tract, it will increase the secretions, it will increase peristalsis. In the neuromuscular junction, it increases the levels of acetylcholine, which will result in action on NM receptors. This will result in muscle contraction. In the heart, increased levels of acetylcholine will produce reduction in heart rate, reduction in AV conduction, and both these effects will result in bradycardia. It will also produce reduction in cardiac output. So these effects are produced by the action of acetylcholine on M2 receptors. And in the glands, it will produce increased secretions, that is increased salivation, increased lacrimation. These agents will also increase the tracheobronchial secretions. In the urinary tract, this produces urination. This is by contraction of detrusor and relaxation of sphincter. Contraction of detrusor is produced by the action of acetylcholine on M3 receptors, whereas the relaxation of sphincter is produced by the action of acetylcholine on M2 receptors. Now we will see the absorption, distribution, metabolism and elimination of these anticholinesterase. All the anticholinesterase, they are absorbed from the skin. Except two agents, these are neostigmine and pyridostigmine. So these agents, they are polar, or they have a charge. So charged molecules will not be able to cross membranes very easily, so they are not absorbed from the skin. Similarly, all the anticholinesterase cross blood-brain barrier, except these two charged molecules, that is neostigmine and pyridostigmine. So these are the significant pharmacokinetic properties of anticholinesterase. Now we will see what are the uses of anticholinesterase. These agents, they are predominantly used for atony of bowel. Atony means reduced tone of or loss of tone of bowel. So this will result in reduced peristalsis. So these agents, they will increase the levels of acetylcholine, thereby promoting peristalsis. These agents, they are also used for atony of bladder. So this will result in urinary retention. So by increasing the levels of acetylcholine, these agents will cause contraction of detrusor and relaxation of sphincter. This will result in urination. So the atony of bowel and bladder, they are usually seen after surgical manipulation of bowel and bladder. So in this condition, we commonly use neostigmine because neostigmine does not cross blood-brain barrier. And these effects, they are seen in the periphery. And we only need the effects in the periphery. So that's why we prefer neostigmine. And for this condition, we usually give subcutaneous injection of neostigmine. Anticholinesterases, they are also used for the treatment of glaucoma, and they are used as a last resort. So if no other treatment is working, then you can go for anticholinesterase. So they are not first choice agents. So how they act is by producing constriction of ciliary muscles and this constriction will result in increased aqueous flow. Another use of anticholinesterase is a condition called as Myasthenia Gravis. So this is an autoimmune condition where autoantibodies are produced against the nicotinic receptors, especially NM receptors which are present in the neuromuscular junction. So stimulation of NM receptors is essential for muscle contraction. So when antibodies are produced against NM receptors, this will result in reduced number of NM receptors. So that will result in reduced action and which will result in muscle paralysis or muscle weakness. So this muscle weakness can occur in extraocular muscles. So weakness of extraocular muscles can result in diplopia. And weakness of muscles around the eyelids can result in ptosis. Weakness of muscles around the mouth and around the throat will result in difficulty in swallowing and chewing. And the person will be complaining of weakness. And this weakness will be typically seen towards the end of the day. And this weakness is typically seen towards the end of the day because in the morning the nicotinic receptors, NM receptors will be more active and acetylcholine will produce the action. But by the evening time, these lower number of nicotinic receptors will get desensitized and that will result in reduced muscle contraction and that will produce weakness towards the end of the day. So if a person is having myasthenia gravis, or if a person is coming with symptoms of weakness towards the end of the day, you can test it by giving a substance called as edrophonium. Edrophonium at a dose of 2 milligram is given intravenously. So this edrophonium is a anticholinesterase. So this agent will inhibit the acetylcholinesterase, and this will result in reduced metabolism of acetylcholine, resulting in increase in levels of acetylcholine. So when there is increased levels of acetylcholine, there will be improvement of symptoms in myasthenia gravis. So this test is known as edrophonium test. Two anticholinesterases are used for the treatment of myasthenia gravis, pyridostigmine and neostigmine, because these two agents does not cross the blood-brain barrier, and myasthenia gravis is a peripheral disease. So we need only action in the periphery. So these two agents, they only have action in the periphery, and that is why these agents are preferred in myasthenia gravis. In myasthenia gravis, there will be production of autoantibodies against the NM receptors. So corticosteroids, they are immunosuppressants. So corticosteroids will reduce the production of autoantibodies, which will result in reduced destruction of NM receptors and improvement in symptoms. So corticosteroids will produce improvement in symptoms of myasthenia gravis. Other groups of agents which are used for the treatment of myasthenia gravis are immunosuppressants. Like azathioprine and cyclosporin. These agents will suppress the immune system, thereby reducing the production of autoantibodies. Thereby improving the symptoms of myasthenia gravis. The thymus gland helps in maturation of antibodies and also various components of WBCs. So removal of thymus or thymectomy can produce improvement in symptoms in myasthenia gravis. Anticholinesterase is also used in a neurodegenerative condition called as Alzheimer's disease. So in Alzheimer's disease, there is degeneration of cholinergic neurons. In the nucleus basalis of Maynard, and this is associated with dementia. Dementia means forgetfulness. So in Alzheimer's disease, we need agents that cross the blood-brain barrier and produce an increase in levels of acetylcholine in the central nervous system. So these agents are used: rivastigmine, donepezil and galantamine. These three anticholinesterases, they will cross the blood-brain barrier and reduce the metabolism of acetylcholine in the central nervous system, thereby increasing the levels of acetylcholine. So they are used for the treatment of Alzheimer's disease. Now coming to the most important part in the session, poisoning with anticholinesterase or organophosphate poisoning. So this is an important short note question, and also it can be asked as an essay question. So please pay attention. So these organophosphates, they are commonly used as insecticides. And these agents, they do not have any charge, so they can be absorbed from the skin. So while using these insecticide, if the insecticide gets into contact with your skin, it can get absorbed from the skin. And if it is sprayed as microfine particles, it can be absorbed from the lungs. And some people also consume this as an attempt of suicide. So these are the common exposures to organophosphates. So these organophosphates will inhibit the enzyme acetylcholinesterase, and this will result in increase in levels of acetylcholine. The symptoms produced by organophosphate poisoning are due to stimulation of acetylcholine on various muscarinic receptors. These include sweating, diarrhea due to increased peristalsis, increased gastrointestinal secretions, and relaxation of sphincters. These agents also produce urination due to relaxation of bladder sphincter and contraction of detrusor. Acetylcholine also acts on the eye and produce miosis. So this is one symptom that will be helpful for your diagnosis in the examination. Sometimes in the question it will be given as the patient is presenting with pupillary constriction, or sometimes it can be given as pinpoint pupils. So this is diagnostic of organophosphate poisoning. One other poisoning produces this miosis or pinpoint pupil. This is with opioid poisoning. So how can you differentiate this opioid poisoning and organophosphate poisoning? Usually in patients who are having opioid poisoning, they will be having injection marks in the skin, and also this organophosphate poisoning is associated with increased secretion, salivary secretions, lacrimal secretions, etc., diarrhea and urination, whereas opioid poisoning, there will be absence of these symptoms. Organophosphates will also increase the acetylcholine in the lungs, that will result in bronchospasm, can result in vomiting, lacrimation and salivation. So these symptoms, they are absent in opioid poisoning. There is a mnemonic to remember these symptoms: dumbbells. D is diarrhea, U is urination, M is miosis, B is bronchospasm, E is emesis, L is lacrimation, and S is salivation. So for all emergency situations, you will have to do three things: airway, breathing and circulation. So this is an emergency situation. You will have to check for the airway, breathing and circulation. If you are suspecting absorption of organophosphate from the skin, you will have to undress the person and wash him thoroughly, so that there won't be any further absorption from the skin. If the absorption is from the gastrointestinal tract, you have to wash the stomach wash, or it is otherwise known as gastric lavage. So the symptoms of organophosphate poisoning are due to excess amounts of acetylcholine. So you have to give anticholinergic agents for this organophosphate poisoning. And the anticholinergic agent used is atropine. And atropine is given at a dose of 2 mg every 5 minutes until the symptoms of muscarinic activity disappears. So organophosphate compounds, they bind to acetylcholinesterase. And initially this bond is reversible. So as time progresses, this bond becomes irreversible. So this process is known as aging. So if you are administering agents which have more affinity to organophosphates, this organophosphates will leave this acetylcholinesterase and bind to these agents. So these agents, they are called as oximes. This is acetylcholinesterase and organophosphate. So before aging, if these oximes are administered, this will result in reactivation of acetylcholinesterase. Hence these agents, they are called as cholinesterase reactivators. So to summarize, parasympathetic nervous system is called as rest and digest system, and the effects produced by stimulation of parasympathetic nervous system is what happens when you are resting. So the major neurotransmitter of parasympathetic nervous system is acetylcholine. Acetylcholine produces its action by acting on two types of receptors, muscarinic and nicotinic. Muscarinic receptors are M1, M2 and M3, whereas nicotinic receptors are NM and NN receptors. So the cholinergic drugs, they are classified as directly acting cholinergic agents which act on the cholinergic receptors, and also indirectly acting agents. The directly acting cholinergic agent used is pilocarpine, and it is used for the treatment of glaucoma as a last resort. These indirectly acting cholinergic agents, they will inhibit the enzyme acetylcholinesterase. So these agents will increase the levels of acetylcholine, thereby producing improvement. So these agents, they are used for the treatment of a condition called as Myasthenia Gravis, which is an autoimmune disease where antibodies are produced against the NM receptors. So these NM receptors, they are present in the neuromuscular junction, and stimulation of these receptors will result in muscle contraction. So destruction of these receptors will result in weakness. Since Myasthenia gravis is a disease of periphery, we need agents that act in the periphery and which does not produce any effects in the central nervous system. So the agents used are neostigmine and pyridostigmine. So these agents, they will inhibit the acetylcholinesterase, increase the levels of acetylcholine, and it will produce improvement in symptoms. And also immunosuppressant drugs like corticosteroids, azathioprine can be used, and also thymectomy is a treatment option in Myasthenia gravis. These agents, indirectly acting cholinergic agents, they are also used for Alzheimer's disease, which is a neurodegenerative disorder where cholinergic neurons are destroyed in the central nervous system. So the agents that cross blood-brain barrier are used for the treatment of Alzheimer's disease. And the most important part in this session is organophosphate poisoning. These organophosphates, they are irreversible anticholinesterases. So these agents, they can be absorbed from the skin, they can be absorbed from the respiratory tract, and they are also often consumed as suicidal attempts. So if a person is coming with organophosphate poisoning, you will have to wash the person, you will have to give gastric lavage if the person has ingested the organophosphate. So the symptoms of organophosphate poisoning, it can be remembered by the mnemonic dumbbells: diarrhea, urination, meiosis, bronchospasm, lacrimation, emesis, and salivation. So these are the symptoms associated with organophosphate poisoning, and it should not be confused with opioid poisoning, because in opioid poisoning there won't be diarrhea, there won't be urination, there won't be lacrimation, there won't be any salivation. So these are the identifying points for organophosphate poisoning, and for organophosphate poisoning we give atropine 2 mg every 5 minutes till symptoms subside. And another agent, cholinesterase reactivator. Oximes. So these agents, they have got affinity towards this organophosphate compounds. So before the bond between acetylcholinesterase and organophosphate become permanent, if you are administering oximes, it will result in dissociation of this organophosphate from the acetylcholinesterase enzyme and binding to these oximes. So these agents, they are called as cholinesterase reactivators. So guys, this session is a very favorite topic for Viva Voce, and Myasthenia Gravis, organophosphate poisoning, Alzheimer's disease, all these questions are usually asked in the theory examination. So please remember to revise this before you go for the exam. Thank you.